Upper limb trauma is important in trauma, but nowadays we are seeing that spine, more and more number of things are coming. They usually start with the basics, the cervical spine that curves inwards towards the body. Normal curvature of the cervical spine is inwards. That's called as cervical lordosis. Thorax goes out, thoracic kyphosis, lumbar lordosis, and then the sacrum. The question asked, what's the normal curvature of lumbar spine? Lumbar lordosis. But when it's exaggerated lumbar lordosis, what are the causes? Remembered by the mnemonic SOAP. S, spondylolisthesis, slipping of one vertebra over the other. O, obesity and osteoporosis. A, achondroplasia. P, postural. These are the causes of exaggerated lumbar lordosis. What is scoliosis? Scoliosis means lateral curvature of spine with the rotational element of the vertebra. When I look at the scoliosis, it can be idiopathic, where you can't find any structural element, but the curve is fixed. It can be congenital. In congenital scoliosis, you have a vertebral anomaly right from the childhood. Or it can be a postural scoliosis. Because of any disorder, a patient is obtaining that position, so it looks like tilted trunk. There is a classical test called as the Adams test for scoliosis, in which if you bend forward, and if it is a postural scoliosis, non-structural scoliosis, the spine will again become straight. So this is called as a forward bending test or Adams test. Regarding the congenital scoliosis, you can have block vertebra which are fused, unsegmented area on one side, or a fusion along with half vertebrae on the other side. You can have fully segmental vertebra, semi-segmental vertebra, or you can have a wedge vertebra. All these are structural changes called as congenital scoliosis. When you look at the measurement of scoliosis, Cobb's angle is done for it. You go till the top of the curve and the bottom of the curve. So when you draw a line at the top of the curve and you draw a line over the bottom, the line between the perpendiculars over these lines is the angle between the two. The angle between two lines is same as the angle between the perpendiculars to each line. This is Cobb's angle. Cobb's angle is important to quantify and treat it. Cobb's angle of less than 30 degrees, observation. 30 to 45 degrees, brace. Normally, the scoliosis occurs in lower dorsal spine or the lumbar spine. And beyond 45 degrees, you need to apply a corrective surgery. So these are the surgeries to correct, and these are the braces, Milwaukee or the Boston brace for scoliosis. Also, you have to look at the progress it's occurring or not. If a patient has almost fused skeletal maturity, not occurring further, it means the scoliosis won't change much with the growth. So, as you go from anterior superior spine to the posterior superior spine, and you divide the iliac crest, iliac apophysis into different parts. So, if there is a fusion, riser sign 1, the first 25% fuses. 2, 25 to 50% fuses. Then next 75, and then 4 and 5 is complete fusion to the ilium. So in riser sign 4 or 5, surgery is carried out if the curves are more than 45 or 50 degrees. Riser sign 1 and 3, you observe because there's a chance it can correct as the child grows. Looking at different fractures in the spine, Jefferson fracture is a fracture involving the atlas. Remember the mnemonic Jefferson atlas chart. It's a vertical compression injury, burst fracture. Hangman fracture is like a spondylolisthesis, slipping of C2 over the C3. If you have to choose one, hangman is C2, H2. Clay-Chauvel's fracture is a fracture of lower cervical spine process more than the upper thoracic spinous process. These are the important fractures. Then one more fracture in the cervical spine, which is known, is hyperextension followed by flexion. So if you're going in a high-speed vehicle, the sudden brake, your spine will go back and then come in front. This is called as a whiplash injury, where there is a hyperextension followed by flexion. And then you have one classical term, spinal cord injury without obvious radiological, means X-ray abnormality. Gene in child less than 8 years. So X-rays are normal, but they have spinal cord injury, so can be picked up on MRIs. When you have to give a traction to the cervical spine, or you want to reduce a fracture or immobilize a patient, you apply the Crutchfield tongs over the skull, but the traction is given for the cervical spine. Coming to the lower limb, when you look at the Trendelenburg test, it talks about the stability of the hip joint. Our hip joint is stable on what all things? On the head of femur and the acetabulum together, along the liver arm, which is the neck till the trochanter, and the effort, the abductors. So the hip joint, hip abductor, that is gluteus medius and minimus and its nerve supply, and the liver arm, the neck. So there's a fulcrum, there's a load, and there's an effort. So when you look at this axis, what all things to look at? Normal acetabulum, normal head, normal neck, gluteus medius and minimus, and their nerve supply. When all of them are normal, normally when I stand on both the limbs, my body weight is equally transmitted on right and left. Human hip is a very strong structure. Supposedly, my left hip is normal and right is diseased. So when I stand on the left hip and I lift on the right lower limb, with gravity the right side should fall down. But because the hip abductors, their nerve supply, and the hip joint along with liver arm, the femur neck are intact, they will raise my opposite pelvis and will not allow it to drop. So normally, normal limb, when you stand, the opposite side does not drop. The opposite pelvis does not drop. This is called as normal and negative. Negative means Trendelenburg test is negative, does not fall. When you stand on the diseased hip, with gravity, the left side falls, the opposite side falls, it's diseased, can't lift it up. So there's a drop on the opposite side of the pelvis called as positive. This is positive, means drop of the pelvis on the opposite side. When it's positive on both the sides, that's how it drops. You wear weight on the right, left drops, left, right drops. So this is called as a waddling gait, duck waddles. So bilateral diseases, bilateral Trendelenburg test positive, waddling gait. Hot favorite of the examiner. But the number one area, Thomas test. For hip flexion deformities. Thompson test, tendo Achilles tear. So Thompson, people confuse. Thomas is a small word, hip is a small word. Thomas test for hip flexion. Thompson is a big word, tendo Achilles is a big word. Tendo Achilles tear, Thompson test. Remember this. When you look at the columns of the pelvis, when you have an anterior column and posterior columns, and when there's an injury to the pelvis, and pelvic injury will be disseminated through the acetabulum, and acetabulum is a fusion of ilium, ischium and pubis, so it will dissipate in the entire pelvis. And when there's a fracture of anterior column or posterior column, you can make out by doing a CT scan or a Judet view where you tilt the pelvis and click for the x-rays. But when there's a fracture of both the columns, it's called as a spur sign for bicolumnar fracture. Remember the word Judet? Judet and Letournel classification, Judet and Letournel views for the acetabulum. Upper end of femur is under the force to bear the weight of the upper limb and the trunk to the lower limb to the ground, travels to the hip joint. Along the lines of stress, there will be bone formation Wolff law. That's why here you can see dense bone formation. If I look at the acetabulum, the acetabular trabeculae are in line with the head, with the neck, and they go to the area of calcar, the posteromedial area of the upper end of femur. When there is a fracture of the neck of the femur, the trabeculae between the acetabulum, head and neck, their relationship is altered. So this is how the neck femur fracture look like. This is how the fracture to the intertrochanteric area looks like. And this is the Gardner's classification for fracture neck femur. Gardner's classification says when there is a fracture but it's incomplete, it's grade 1. But the trabeculae of the neck goes into valgus. So it's a valgus impacted fracture. On the lateral side is a fracture, so it goes into compression. Gardner stage 2, it's a complete fracture, no displacement. So all the trabeculae are aligned. Gardner stage 3, there's a partial displacement. 3, all 3 malaligned. 2 for joy, all aligned. 3, all 3 malaligned. Stage 4, the neck goes away. The acetabulum and the head, they align together. Completely displaced. Gardner stage 1 and 2, they behave similar in treatment and prognosis. Stage 3 and 4, similar in treatment and prognosis. When I look at the upper end femur, there are high forces, and if the forces are vertical, the fractures don't unite. That's why what is the angle of the fracture determines success. The angle that the fracture line makes with the horizontal has been classified by the Powell's classification. Powell's type 1 is angle less than 30. 30 to 50 is Powell's type 2, and type 3 is a vertical fracture where the angle is more than equal to 50 degrees. Type 3, vertical fractures, and remember, vertical fractures don't heal well because horizontal fractures compress and can unite. So when I look at the upper end of femur, this particular image, and when I look at this particular image, in this particular image, it is very, very important that we are able to pick up which area is intertrochanteric, which area is neck. So when I look at this area, along the intertrochanteric area, the capsule inserts. So this is intertrochanteric area, this is the neck area. So intertrochanteric area is outside the capsule, also called as extracapsular. Neck area is intracapsular. So when I draw a table, intracapsular area, also called as neck of fracture, extracapsular area, also called as intertrochanteric. Remember, intertrochanteric is more common. Neck femur, classical is 60-year-old female. Intertrochanteric is usually 80-year-old male. Neck femur has less pain, less amount of shortening, less amount of externodation. All these are more in intertrochanteric because I remember it like this: extra incidence, extra age, extra symptoms, extra shortening, extra externodation. Extra is everything extra. When I look at the foot end, there is marked shortening, complete externodation. This is extracapsular intertrochanteric. Mild shortening, mild rotation, fracture neck of femur. And that's how you look at it. This is the classical thing that you must remember, that extra, there is everything extra. So neck femur, the externodation is less than 45 degrees. Intertrochanteric is more than 45 degrees. Classical point, lateral border of the foot touches the bed. Classical. So intertrochanteric fractures, they are known for malunion. Neck femur fractures, they are known for avascular necrosis more than non-union. So when I look at the incidence of avascular necrosis in neck femur, as we go from the head to the intertrochanteric, the incidence goes down. Just beneath the head, subcapital, maximum chances, transcervical, lesser, intertrochanteric even lesser. This is anatomical classification of proximal femur fractures. When I look at the treatment, intertrochanteric fractures are more common. Treatment today, without opening the area, reduce it, put a nail fixed with a screw called as cephalomedullary nail. Cephalo means head, going in the head and the medullary component, also called as the proximal femoral nail. Not long ago, the classical treatment was put a screw, hip screw, over it slide a plate, fix the plate to the shaft. Dynamic hip screw, because as the fracture unites, it will collapse inside. Dynamic hip screw. But now, number one treatment is the nail, proximal femoral nail. When we look at neck femur, less than 65 years of age, less than 3 weeks of the fracture, less than equal to 3 weeks of the fracture, treatment is simple screw fixation. Less than 65 years of age, more than 3 weeks of fracture, because the chances are less, cambium layer is not there, forces of vertical combination is there, either do a bone graft or do an osteotomy. The aim is to make the fracture line more horizontal, because the lesser the Powell's angle, the better is the union. More than equal to 65 years, treatment is hemiarthroplasty. Any age, if there is cartilage destruction of joint, arthritis, joint space reduced, you will do a total hip replacement. So if fracture neck femur plus arthritis, you will do a hip replacement. Coming to the next common area, in fact, the commonest question asked, fracture shaft femur. Gallows traction is used in the age group less than 2 years of age. Child is hanging by the roof, buttock of the bed for a period of 6 weeks. Thomas splint is to immobilize the lower limb, was classically given for TB knee, but now is to immobilize the lower limb, giving a fixed traction mainly in shaft femurs. Thomas splint with a fifth splint is to have dynamic mobilization of the knee in that. When you apply a plaster of Paris on the one surface, it's called as a slab. S for surface, S for slab. When you apply plaster of Paris circumferentially, C for cast, C for circumference. When the cast goes around the spine, spica. This is a spica. Plaster of Paris is calcium sulfate, half H2O. When you add water to it, it becomes calcium sulfate 2H2O, releases the heat, exothermic reaction. Setting time is 7 to 10 minutes, which is also the setting time for the bone cement. So age-wise treatment of fracture shaft femur, when the child is less than 5 years, spica. So even less than 2 years is spica. Gallows is only an option. 5 to 10 years, you will put a nail under the X-ray control C-arm machine called as titanium elastic nail system, and more than equal to 10 years, interlock nail. You will pass a nail and fix it with the screws to the shaft, so there is no malrotation. Earlier times, the nails used for fracture shaft femur were designed by an obstetrician, Kunscher's nail, but now we have interlock nails where a nail is put inside the femur and locked with the screws. Fracture shaft femur. After 48 hours, patient is breathless. Think about fat embolism. You have C for compartment, cast. M for myositis, massage. S for Sudeck's dystrophy, sympathetic overactivity. Femur fracture, 48 hours. Fat embolism. I told you, usually fat embolism is after 48 hours, but nowadays they are giving you scenarios in lesser time. There will be petechiae, PaO2 less than 60, pulmonary edema, and CNS depression. Whereas minor criteria, fever, tachycardia, anemia, thrombocytopenia, fat in sputum, fat in urine, increased ESR, retinal emboli. So 1 major plus 4 minor is equal to fat embolism. The drug of choice is oxygen. Fat embolism is managed in ICU. The ventilatory mode of choice is intermittent positive pressure ventilation. Drugs of research, hypertonic glucose, because they decrease the free fatty acid production. Lipolytic activity of heparin decreases the platelet aggregation, the proteinin. Dextran, which decreases the RBC aggregation. Only other drug apart from oxygen of proven benefit is steroids, which prevent pneumonitis. Compartment syndrome cast, myositis massage, sympathetic overactivity Sudex, femur fracture 48 hours, fat embolism. That's how you should remember. If there's a fracture involving a joint above, a bone, major bone above the joint, and a major bone below the joint, is called as a floating joint. Floating elbow, humerus and ulna. Floating knee, femur and tibia. Treatment, fixation. This is what you should remember. When we look at subluxation, it is partial loss of contact between the two joint surfaces. When we look at dislocation, there is complete loss of contact. Hip dislocation is not as common as the shoulder dislocation, but it is more posteriorly, shoulder anteriorly. When we look at the head of femur or humerus, in anterior dislocations, they will go down below the joint and the limb will be abducted down and out. In posterior dislocation, the head will be at the level of the joint or above it, and the limb will be adducted up and in. Now, classical presentation of a hip dislocation when it's anterior will be flexion, abduction, externodation of the lower limb. For a posterior dislocation, which is more common, flexion, adduction, internal rotation of the lower limb. Remember, when it's a pure dislocation without a fracture, Faber and Farder will be seen. But if there's a fracture, either of the femoral head or the acetabulum or both, then the classical Faber-Farder will not be seen. That's called as atypical presentation. Anterior dislocations will have lengthening. Posterior dislocation or any other dislocation will have shortening. So basically, you can have 4 varieties: anterior, posterior. You can have central, where the head breaks the acetabulum, goes in the pelvis, and posterior fracture dislocation. Posterior fracture dislocation is also called as Pipkin's type 4. So anterior will have lengthening, posterior shortening, central means inside the pelvis shortening, posterior fracture dislocation shortening, anterior Faber, posterior Farder, and they will not have Faber-Farder, they will have some other combination, atypical. That is the classical thing that you must remember. Also remember one thing: where is the head? In anterior, it's in the femoral area. Posterior, gluteal area. Central, inside the pelvis, felt on per rectal examination. And in posterior fracture dislocation, whatever remnant after the fracture, gluteal area. How do you pick up on the questions? The part that moves with the rotation of the thigh or the shaft is the head of femur. This is one image that one should remember. Let's have a look. What is it showing? Hip flexion deformities. Thomas test. Very commonly asked in entrance exams. Then shortening of the limb along with external rotation. Classical of fracture neck of femur and intertrochanteric fractures. The difference in shortening externodation may vary, but all will have shortening externodation. Flexion, adduction, interrotation. Posterior dislocation. Flexion, abduction, external rotation, anterior dislocation. Thomas test, number 1 asked question. Anterior dislocation, number 2 asked question. Neck of femur has also been asked. This is what I believe will be asked in future a lot. So let's understand what we have done. When we look at this image, you can see the flexion, abduction, external rotation of the lower limb. This is anterior dislocation. Where will you feel the head? Anteriorly. What will be there? Lengthening. Look at the head below the joint, arm, thigh abducted. So there is down and out. As compared to it, if you're sitting in a car, high-speed vehicle, there's a sudden brake. Your knee will strike against the dashboard. If the force goes around the femur, there will be posterior dislocation called as dashboard injury. And if it goes around the knee, there will be avulsion of posterior cruciate ligament. The most posterior structure at the upper end of tibia is PCL, avulsion. Both are dashboard injury, but dislocation is more common answer. So in posterior dislocation, you will have flexion, adduction, rotation, and shortening. The head will be gluteal, will be at the level joint, thigh adducted. The femoral artery, it goes in this area. You feel the femoral artery pulsations along the head. Normally, when you feel the femoral artery pulsation, it's called as vascular sign of Narath. The femoral artery pulsations are felt or negative. In posterior dislocation, the vascular sign of Narath is positive because there is no surface to palpate the artery, called as vascular sign of Narath positive. All the femoral artery pulsation not felt in posterior dislocation. There is a vertical force, the head goes in the pelvis, called as central fracture dislocation, also called as central dislocation. It is felt, the head is felt on per-rectal examination, shortening, atypical feature, neither Faber nor Fadel. Whereas when there is a fracture of the head along with acetabulum, it's called as Pipkin's type 4. The head is gluteal. Classical deformity of Fadel is not there. There is shortening. So shortening with a gluteal mass with atypical features is the Pipkin's type 4. So fracture dislocations is Pipkin's type 4. Central is also fracture dislocation, but classically is a misnomer. And there is head per rectal with shortening. Posterior, 90% of cases of hip dislocation, Fadel with shortening, and the head is gluteal. Anterior, Faber with lengthening, head in the femoral area. Remember, any mass that moves with the rotation of thigh is the head of femur. Angles in orthopedics. When you look at the area around the calcaneum, and when you look at the angle called as the Bowler's angle, it's an angle which is along the joint line and the calcaneal tuberosity, also called as tuber joint angle. Normally is 20 to 40 degrees. With the fractures of calcaneum, this goes down. Whereas the angle of Gissane is the angle on the articular surface. It's at the normal value of 95 to 105, and this increases with the fractures of calcaneum. Gissane, gain. Bowlers, lowers. The other angle, Q angle, is a pull of the quadriceps. It is from the anterior superior spine to the central of the patella, and the second from the central of patella along the tibial tuberosity ligament of patellum. This is the Q angle. The Q angle, when it's increased, it means there are higher chances of patella subluxation or dislocation. Then Insol-Salvati ratio. It is a ratio between the ligamentum patellae, labeled as A here, means the lower pole of patella till the tibial tuberosity, and the maximum length of the patella. Normally it's 1:1, so the ratio is 1. If the ratio is less than 0.8, it means the patella is low-lying, patella baja, and It's not Baja, it's Baha. And when the ratio is more than 1.2, it's patella alta, high altitude. In either case, you have more chance of patella subluxation or dislocation. Some more angles. Kite's angle. He was the king of CTV. Congenital talipus equinovarus, also called as clubfoot. Cobb's angle, which is for scoliosis. Nowadays, they are asking you Cobb's angle a lot. Some important splints and casts in orthopedics. You're going to expect a lot of questions coming on them. Hanging cast, H for hanging cast, H for humerus. U-slab, again for fractures of humerus, upper limb. Cylinder cast, it is for fractures of patella. Very, very important. Patellar tendon bearing cast, although has a word of patella in it, it's for fractures of tibia. Glass holding cast, scaphoid. Hand shaking cast, Colles. It's exception to the rule of splintage below elbow. Tractions, Dunlop traction and Smith traction for supracondylar fracture humerus. And remember, Smith traction is not for Smith fracture. It's for supracondylar fracture humerus. Figure of 8 bandage for the most common fracture in human body, clavicle. I think this question is going to come. Mallet finger. What is a mallet finger? Avulsion of extensor tendon from the distal phalanx. Gallows traction, one of the commonest MCQ asked. Mallet finger, again one of the commonest MCQ asked. Treatment, avulsion of extensor tendon from the distal phalanx. Treatment, mallet splint for a period of 6 weeks. Then we have the Ball-Brown splint, which is used for the fractures of femur, the knee injuries and the tibia. Then you have a Russell traction, which was classically described as a skin traction, now used as a skeletal traction for the trochanteric fractures and the femoral fractures. Agnes hand traction, which is for the flexion deformities of the hip. Milwaukee brace for scoliosis.